Hi, Srilakshmi. Are you starting now? Hello? Can you hear me?
Okay.
Yes, ma'am. We are starting.
Yeah, okay. I'm there. You can start.
Okay. So, yes. So, good afternoon, everyone. Welcome, audience. So, today we are having an interesting debate on the topic: is the era of biologics in spondyloarthritis over? We have known that for last couple of decades, biologics are an important in treatment of spondyloarthritis. But now the newer smaller molecules and other therapies have been an alternative in treatment of spondyloarthritis. So today we have a debate in the department. So for this statement, Dr. Srilakshmi is speaking, and against the motion, Dr. Deepti will be speaking. So I welcome both the participants to present their views in front of all of us. Enjoy the debate.
So good afternoon. So today's debate topic you all know. So I'll be going for that is is it an end of an era? Yes, of course, it is ended. That's what I would say. So as my slide depicts, we know that I've started my slide with the negativity of against things. So we all know that how this situation was just a decade ago, how it was, how the patient was so anxious, the patient did not have money, we were not able to give the biologics, and the clinician was so worried what to do for the patient, and we were there. But currently, we are all happily sitting in the OPD and writing hundreds of prescriptions. I would say that will be very less. So let's start with a good note. Has your life changed as a clinician after the JAK era, sir? Yes. See? Okay. I know my opponent is going to talk about it is the best, it's the most efficacious, it gives relief failure, blah, 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 blah. All that I am aware of it. But then let's go and see what's happening. So living in Pune, if you see, there are multiple routes to the airport, but all are time taking, all are time consuming, and all are painful. There is no one proper route to the airport. Similarly, when there is a disease, you'll all have different medications, different injections, different tablets, and everything. But all are going to be equally painful, but everything does the job. Similarly, one more thing for that, all your cytokines, TNF alpha, interleukin 17, 23, finally are all going to come up to your JAK-STAT pathway. Hitting this is almost going to be equally hitting all your previous cytokines. So I say all roads lead to the same destination. What is the point of using something more expensive and everything? Let's see. I think all of you remember this doll, which was very, very, very popular in Netflix. And JAK inhibitors is like this doll. Whoever comes in its way, whatever disease it is going to be, it is going to kill it. Say not only SPA, even RA, everything else, it is going to give it. So coming to the efficacy, okay, this is where there's going to be a hard tough to prove that I'm equally efficacious to the other injections and other molecules. So first looking at this, you'll be able to see the pointer. Yes. So these are the studies and the combinations of all the studies of tofacitinib, JAK inhibitors, also upadacitinib, figlotinib. So you have your, this is radiological SPA and non-radiological SPA. So we have to see this is tofacitinib, this is figlotinib, these are upadacitinib and compared with a placebo. So these are your ASIS 20, ASIS 40. You can see the efficacy of your JAK inhibitors in these patients is almost 56% in the other study, and in Tortuga, the figlotinib is 76%. And the recently FDA approved upadacitinib is also, if you see in select axis 1 and select axis 2, in both radiological SPA as well as in non-radiological SPA, the efficacy is almost 65%, which was in axis 20, 52, and 65.4% in select axis 2. And basically, what was happening is they had compared in select axis 1, they had taken the upadacitinib and they've seen the response in terms of your axis 20, axis 40, and your BASTI. And the efficacy was almost 65%, a response was there. And when you compare it with your axis 40 of your injectables, when you see adalimumab, certolizumab, etanercept, the percentages are not much of a difference. If you see, it's almost 60, 65%. Here, so it is 41%, 48%. Not much of a clinical difference. And also it has been, your tofacitinib, upadacitinib has been approved for your non-radiological axial SPA. And your radiological axial SPA, upadacitinib has been approved. In psoriatic arthritis, again, both has been approved. And also in your ulcerative colitis, IBD-associated SPA, your tofacitinib and upadacitinib has been approved. So, yes. Next. Okay. So, this is one more slide comparing your different adalimumab agents and your ASIS 20, ASIS 40, and your remission versus, look at the numbers, 56, 29.4, which is placebo, and your ASIS 40 in your tofacitinib group is 40.6. And when you, which was for tofacitinib, when you see upadacitinib, it's again 65.4 and 45%. Yeah, obviously, your injectables are a little bit, which is showing 68%, but then again, it comes back at as 40 to 40, 54%, 54.54%. Which one? Yeah, this was at 40, it was upadacitinib. The select was for upadacitinib. Tofacitinib was 40.6, and this was 45, which is 54. Yes, it is a little bit better than, I wouldn't say that, obviously this has a better, I would like to accept that they did not have that much response compared to your infliximab, but it is almost thing. And there has been no trial which is comparing head to head with tofacitinib and your TNF alphas. And when we had discussed this with even the other sir said, obviously, when I'm going to compare both groups are going to say that both are going to perform almost equally. So yes. So that is the reason nobody is even daring to do the head-on trial. Okay, so this is a Sukra graph, which is going to show the efficacy of your TNF, IL-17, IL-23, your placebo, and your TNF, your JAK inhibitors. As you can see, your blue line here, your blue line is your interleukin-17, red line, which is on the top, is going to be your TNF alpha, then your yellow line is going to be your JAK inhibitor. Immediate response, immediate thing is going to be in your TNF alpha. But in the long run, if you see, everything is going to reach in par with it. Whether your ASIS 20, ASIS 40, or your response, which is 5 out of 6, is also. But when you look at the adverse effect also, the line is in the lower end when compared to your interleukin 23, interleukin 17, and your TNF alpha. So adverse effects are also comparatively low when you compare it with your TNF alphas, interleukin 17s. And so your adverse effects are also less, and the time taken to reach is a little bit more, but then it is reaching the point which it has to be reached. Sukra is a graph which they, I had actually read it, area of the curve. Coming to about IBD-associated axial SPA, if you look, there have been a lot of trials on tofacitinib and the clinical response at 8 weeks, 12 weeks. And these are the trials, Octave 1, Octave 2, Sustain. And when we had compared it with the, there are multiple trials individually comparing TNF alpha with placebo and your tofacitinib with your, or your upadacitinib with your placebo. And all of them have shown similar results between the two groups. So Again, uveitis and JAK inhibitors, we know that there are not many trials, but whatever case reports, they've all gone into your remission in cases whenever they had started with tofacitinib. And here I would also like you to tell, in this select access trial, many of the patients who were included in the select access trial were either treated with NSAIDs, or they were also previously treated with TNF alpha inhibitors, and who were not responsive, non-responsive people who had response to upadacitinib. It has become like whoever is not responding also, they have to be shifted to these kind of medication, that is tofacitinib. So yes, it's like your Daryl Mitchell catching the sixes in all around the field. Uveitis, psoriasis, axial SpA, IBD, everything. Your tofacitinib and your upadacitinib can take care of it. Then why do you even diagnose? Just start on tofacitinib. And that is what the world is also, rheumatologists are trying to do. If you don't know the diagnosis, or if you have a disease which is not getting controlled, just put on tofacitinib. It will take care of it. Now it has been expanded that even skin, alopecia, areata, everywhere it has been come. So I think this is a miraculous medication. Coming to the economics, sir. Apples are expensive, but jack of all trades are always Android. Still, I think many of us use Android devices and for studying. Yes. So I think all your features are advanced in Android, and Apple just trying to catch it up. Yes. And coming to this study of economics of comparing your JAK inhibitors versus your TNFs and other injectables, if you see the cost effectiveness, all of them has said, most of the studies have showed that they are cost effective, at least in India. If you compare it in US, probably they are going to be in par with each other. But when you see it in India, the overall economics is much easier, and it is much more easier to convince the patient to start them on this medication rather than start them on the injectables. This is a meta-analysis. This doesn't have Indian data, sir. Which one? US dollars. Yeah, US dollars spent. This was based on US. So yes, definitely it is going to end, because when you have something very simple, something which is non-invasive and which is very cost effective, and which is also showing miraculous data even in everyday OPD, I think we can just shift over our thing. And this also I wanted to tell one more point. How to stop, when to stop, no proper guidelines for any of the TNF alpha. There are studies. This is one of the study which is showing how they had tapered the adalimumab. For example, initially they had given 40 mg 14 days apart. Then they had given 66, it is 40 mg 21 days apart. Then they had given 40 mg at 28 days interval, and then they had stopped TNF5. But most of the studies have shown that after stopping the adalimumab, most of the patients had gone into a small or a medium flare. But how do you prevent it? You have to come back to your small molecules, which you can take it for a longer term, and it's also less effective. So obviously the light at the end of the tunnel is your JAK inhibitors. Even if you have to stop, then you have to come back to us. There is nothing more in here. We don't even have more of data how to stop the thing. Yes. And there was one more study which was actually interesting, not related to axial SpA, but the study was comparing how to change over from TNF5s to tofacitinib in rheumatoid arthritis patient, where they have shifted the patient from Adali to Tofa, Tofa to Tofa, and Adali to placebo. And they found that whoever shifted from Adali to Tofa still were in remission, and it was almost the same. Most of them did not flare back. Tofa to Tofa, they just continue without flares. but we don't have any case reports or anything published data as of now. So we don't know about it. Now, or yeah, they just studies showing how they have tried tapering it. Now, talking a little bit about the bad things. So the TNFs alpha, we all know that we are different injectable forms. But there was a new paper in the Nature which showed that different injectables have different retention rates. Golimumab had the highest retention rate. And if you see the etanercept and adalimumab, if you can see, they are all having the low retention rate. So over the period of month, the retention rate of the medication is also decreasing. So over a period of time, long term, you cannot still go on with TNF alphas. You have to come back to smaller molecules at some point. Starting with a smaller molecule is also a better option. Which one? Yes, more the frequency, but still lesser is a retention. And when I searched in Google, what is a TB capital? It showed India. And I showed what is a TB capital in India? It showed Delhi. Okay. So this was a study which was showing data around 5,671 randomized patients. 26 cases of tuberculosis were reported only in patients treated with tofacitinib, which is an incidence rate of about 0.21. But when there was 5,853 patients were included in the TNF alpha group, 43 patients, which was around double the time, had TB. So their injectables had more chances of TB in a place where there is more chances of getting tuberculosis. Tofacitinib was comparatively very, very safe. And it was also 50% less. So it's like TNF alpha saying, if you're bad, I'm your dad. So obviously, being first is always not important. Being into remission is always not important. But having quality is more important. And it's economical, easy to convince patient, non-invasive, less infectious, almost as effective as injectables. When you need to taper or a disease flare, even from TNF, your go-to choice is tofacitinib. So I think I've made my point. Last but not the least, I think I've given a lot of names. Tofawal, Tofapur, and Tofayard. We can all produce our own over-the-counter tofacitinib, and you can write your own medicines. I think behind your clinic, you can open a pharmacy for tofacitinib. Yes, thank you. Yeah.
So hello, good afternoon. So after that very flowery presentation, let me put some facts and tell you why biologics are still the boss, will always be the boss, and they need to take training from the boss to become the boss. Okay. So the therapeutic armamentarium for SPA, we all know, is very widespread. We won't be discussing the details of it. This is just to give you an idea that by biologics, I mean all those which are there in purple. So you can see the size of the armamentarium I have versus the size of the armamentarium my opponent has. So you can see the class difference right here. So I'll convince you not only with some language and comics, but I'm going to show you some solid data to convince you that biologics are here to stay and it can never be the end of an era. So first, let us talk about the efficacy and safety. So now let us look at how much data we have. You see how much data we have in biologics. We have 53 trials as opposed to small molecules where we have just a meager 6 trials, and that too in the last 4 years. Okay. So then the next, if you can see here, this is a network analysis graph to show you how much data we have for each molecule. Now, the size of the blot indicates the number of the studies, and the thickness of the blot indicates the number of trials. The number of participants. Just give me 1 second. Yeah. So the line thickness corresponds to the number of trials, and the node size is proportional to the number of randomized participants. So you can see how big you have. This is for all the ASAS, that is for ASAS 20. So this is for ASAS-20, this is for ASAS-40, this is for BASDI, and this is for ASAS remission. So you can see how big of a data we have existing to prove how effective are biologics. Now, not only that, now let's go back to, these are our latest guidelines from ASAS-ULAR 2023, which says what is the strength of evidence for each molecule when you compare in terms of class of biologics, and the strength of the strength of the molecule, if you can see here, the level of evidence is 1A and 1B, which are the topmost quality of evidence. So you can see that they are backed by a really long research of 21 years, which cannot be dismissed to end an era with just 3 years of data. So I was just trying to sit that the other day and make a list of the number of trials that existed for adalimumab, all the TNFIs and IL-17. I'm not going to discuss this, but you can just see how much data we have with a total patient population spanning around 11,500. So which is not a small number. Okay. So this you start from 2006 up to 2018. And my friend was suggesting that we don't have any tapering data. We do have data on tapering, and they are also a part of our guidelines right now. You can go through the latest guidelines, which I'll be projecting on how to taper the medications also. So this is for etanercept, and this is for infliximab, and so on and so forth, and the list is endless. Now, these are a few named trials for the biologics which we have, and you can see the number of trials that are existing way back from 2003. Now, to make it easy for us to know the efficacy, I have put together a few meta-analysis. So this is the meta-analysis for TNFI, which shows the change in BASDI over a period, over the treatment period. Now you can see how strong is the evidence to favor the TNF blocker. This is regarding the change in BASDI. So the pooled mean is, this was almost around 1, and this was around 0.67 for change in BAS5. Okay. And then next, the ASAS-40 response was almost 4.73. Yeah, and this was all about in radiological axial SpA. Now, in non-radiological axial SpA also, TNF blockers have shown equal amount of efficacy. Now, I think my friend got a little confused. The radiological axial SpA has gotten approval for TOFA and upadacitinib, but non-radiological, you only have upadacitinib. There are no trials which are conducted for tofacitinib in non-radiological axial SpA as of now. Okay, and now what about radiographic progression? All the studies which were done on small molecules did not have any data on the radiographic progression, but TNF inhibitors have good going randomized control trials which show the effect on radiographic progression. Now here, this is the forest plot for the sacroiliac joint score for TNF inhibitor, where you can see that even for TNFIs, this is at week 12 to 16. It is known that to prevent radiographic progression, TNF should be used for a duration of more than 2 years. Short term, you cannot see any change in the radiographic progression, but in long term, there is definitely a reduction in the radiographic progression when you use TNFIs. Now, this was regarding the efficacy. I think I've proven beyond doubt they are definitely efficacious molecules. Now, what about safety? Now, this is one slide which is taken from the latest ULAR 2023 guidelines, which goes on to show that none of the TNFIs have any serious life-threatening adverse events as compared to small molecules. Now, this is just a brief chart. I'll show you more safety data in the forthcoming slides. Okay. No, this is only pure TNFI data. The comparison data I have later. I'll show it to you next. So now again, this is one more study for the TNFI data, which I have only for the safety where we have, and this is again all meta-analysis where the relative risk for increased incidence of infection is not even crossing 1 in any of the studies. Okay. Now, coming to the next upcoming group of biologics, that is IL-17 inhibitors. Again, they also have been proved beyond doubt to be efficacious. You have various trials measured 1, 2, 3, 4, 5. And then you have COAST V, W, X, and Y. Multiple trials are there. Again, their efficacy has been proven beyond doubt. And even they have also been studied with regard to radiographic progression. And a head-on-hand trial for adalimumab with secukinumab is under progression, the results of which are awaited. But we don't have any head-to-head trials for TNF or IL-17 with small molecules. So this was regarding the radiographic progression of IL-17. And if you see regarding their safety, again, so the only part where you can see that is concerning probably here, these are non-serious adverse events, which are infusion injection site reactions, if any, which were minimal. But when you see the other reactions like death, treatment discontinuation, major adverse events, none of them cross the midline, meaning to say that incidence of adverse events between placebo versus the biologics was not at all different. So this was just to show that how efficacious and safe are biologics. Now, don't believe me, believe what the guidelines say. I'll show you 3 different guidelines, after which you will be convinced beyond doubt that you can never have an era which doesn't have biologics. So first we have the 2019 ACR Spartan guidelines, then we have the 2022 ACR ULAR guidelines, and the latest 2023 PANLAR guidelines. Now coming to the ACR Spartan guidelines, so see here, the first sentence, they said that similarly, the panel judged that TNFi, secukinumab or ixekizumab should be used over tofacitinib. Now, my friend here can argue that all guidelines are pharma driven, but no, they are data driven. Look at the number of data we have for each of the molecule. That is how the guidelines come up. Now, even in their flowchart, if you see, the first medication which is preferred when you have an active AS despite NSAIDs is TNFi. Only later, much down the line, comes our JAK inhibitors. Okay. Now, this is the 2022 ASAS ULAR guideline, which came up before last year. And again, here the current practice says TNFi or IL-17 over JAK inhibitors. Now, here again, see, only current practice is to start TNF or IL-17, and starting JAK inhibitors again goes with a caveat saying cardiovascular events and malignancies must be considered. I'll show you more data to say what are the adverse events associated with small molecules also. So in this 2022 update itself, they say that the focus is placed on current practice of TNFi or IL-17 because of the longer experience and with a larger evidence base. Also, data from daily clinical practice with JAK inhibitors and axial SPA are missing. Thus, you cannot say go ahead and start JAK inhibitor according to your whims and fancies before judging the patient's pre-existing comorbidities. Now, coming to the latest 2024 PANLAR guidelines also, again, they tell here, only if there's a contraindication to biological DMARD, you go and start a JAK inhibitor. Otherwise, the first line is still TNFi or IL-17. Oh, sorry. I will just keep this here. So again, the same thing here. If there's a contraindication to DMARDs, biological DMARDs itself, you start a JAK. Otherwise, you start again with TNFi or IL-17. See, they mention in their guidelines that there is more evidence for TNF, and as there are data not only from pooled RCTs, but also from large observational studies, and use of JAKs was reported to be associated with an increased risk of cardiovascular events as well as an increased risk of malignancies. Also, regarding uveitis, all the guidelines unanimously say when you have a coexisting uveitis, the preferred choice of a biologic is TNFi, except etanercept, where there is some incidence of a paradoxical increase in uveitis. Apart from that, every other guideline prefers an adalimumab. Okay. Now, there was one interesting term I came across when I was reading the PANDAR guidelines was something called as S-ASDAS, with a simplified ASDAS. Now, we all know how we calculate our regular BASDA and ASDAS. Now, simplified ASDAS, oh, sorry, this should have gone away. But just remember that it is, to calculate ASDAS, you need a mathematical formula. But to calculate simplified ASDAS, you just have to take similar questions to BASDA, patient global assessment, and your ESR, and just divide it by 10. So that is simplified ASDAS, and it has been shown beyond doubt that there exists a good correlation with ASDAS score and BASDA score, even in Indian population. This score came sometime around 2017. So again, these are the current treatment of TNFi approvals. You can, and also IL-17 approval. You can see that pan disease forms TNFIs, including for uveitis, have been approved. So bottom line, from all the guidelines, it says TNF or IL-17 before JAK in both radiological and non-radiological axial SPA. Now, since we don't have a head-to-head trial, there are some studies which try to go ahead and do a indirect comparison by meta-analysis. So let's nail the hammer and put this discussion to rest. Fine. So this was a 2017 one. Unfortunately, I couldn't get the full article of this. I found a more recent 2023 article. So if you can see here, this was 57 RCTs were included and 11,787 axial SPA patients were studied. And to identify the intervention with highest possible effectiveness, like what she told, SUCRA, that stands for Surface Under Cumulative Ranking Curve. So SUCRA values are always expressed in 0 to 100, with as the higher the efficacy, the higher the value. Now, see, that's how the data proves. The TNF inhibitors are up here in every other efficacy. Like if you take for ASAS 20, ASAS 40, for everything else, TNFIs are the highest. followed by IL-17 only, and then down the line comes JAKs. Even when you consider for BASDI 50, as does also everything, TNFs are the highest ranking molecules. So this highlighted that TNFs are the most effective biologics across all evaluated efficacy outcomes. Meanwhile, even IL-17 stand out for the lower risk and superior efficacy. So I think this is how you can take it, like how biologics are and how small molecules are. Now let's compare the safety of both the molecules. Now we all know about the oral surveillance trial, though this is not pertaining to axial SPA. The side effect profile should not change much. This was a very famous trial published in NEJM in 2022. So this showed that the risk for major adverse cardiac events and non-melanoma skin cancer were higher with tofacitinib than with a TNF inhibitor. And see, we can see it for ourselves that the number needed to harm for TNF inhibitor, number needed what 113 when you compare the tofacitinib versus TNF5. That means how many extra number of patients you need to treat per tofa dose given for a harm to occur. That is number needed to harm, right? So again, this is for malignancy, that was for adverse cardiac events. This is comparing it with TNF, na? Number needed to harm. Kahan pe? There, na? Comparison, na? Comparator is TNF. So now, the main concern was the cost. Now let me put that to rest also, saying why cost can never be the major concern. So first thing, let us see by data that what does patient prefer, a pill shot, a pill burden, or a short burden. So this was a study which was done to see the decision-making trend amongst the patients, where it was an interview form of a study, where they found that 50% patients said oral, but 50% also said we are completely fine by taking a injectable or a parenteral medication. So that doesn't mean to say that most of your patients want oral. Some of them don't want a daily pill burden. So this only goes on to show the heterogeneity of the population we have. So socio-demographic factors are rarely helpful in predicting the medication preference. Like how we think that if patient is poor, then maybe he will not prefer. But by data, it was proven that maybe socio-demographic factors are not the only thing that predict a patient's choice. And also 3/4 of a patient had unique decision-making profile. So you cannot put a blanket statement and say that every other patient will prefer an oral medication only, right? And the next thing, so we may think that maybe biologics are less, other people may be less adherent to biologics. So are they less adherent? Now, again, this study found that there was no statistical difference in the adherence between, this was of course in RA because we don't have a similar study in SPA which has happened. They showed that there is no significant statistical difference between patients initiating on tofacitinib or TNF5 when you compare with adherence. So the argument that TNFIs are less adherent because of their injectable nature can be put to rest. Now, the next thing, what about treatment satisfaction? That is what we all strive for, right? That the patient should be satisfied with the treatment you give. So just don't go by a patient's word. We have some solid data here where it says they basically classified the patient into satisfied, somewhat satisfied, or dissatisfied. They saw that, sorry. Yeah. So they saw that most of the patients, did it go away? Huh? So most of the patients who were in the satisfied group were on the biologic medications. So now, addressing the elephant in the room, what about the cost? Now, cost cannot be taken at the face value. When you're evaluating the cost, just give me 1 second. Yeah. So when you're evaluating the cost, you should see something called as incremental cost effectiveness ratio, ICER. That means to say with every increasing cost, what is the quality of life you're gaining? If that is worth it, then the cost is also worth it, because at the end of the day, you're striving for the quality of life and not only getting a treatment which is less costly, but also less efficacious, right? So this is what you do called incremental cost effectiveness ratio. Now these are only 2 abstracts which were recently published in ACR. This is 2014, but I have one more Indian study also. Now it says that adalimumab is cost effective when used according to the treatment guidelines. That means to say that you don't go only by the face value of the cost. You see the effectiveness ratio also, what is being provided by the medication. Now, this was again an Indian study from Vellore, where they said that tofacitinib therapy is compared to early dose de-escalation strategy of adalimumab. That means when you give adalimumab, most of the time we try to de-escalate it after a period of 1 year. That's what the guidelines also say, where you, after a stable period of 1 year, you can try to de-escalate. And that time of de-escalation, the cost effectiveness of tofacitinib and adalimumab are always almost similar, right? And this was a survey done to see what does the patient feel? What are the patient things that come to mind when they are starting a therapy? Cost comes way down the line. You can see patients are more concerned that the disease should not harm me in a long time. I should get relief from the medication rather than the cost. What we all tend to believe that cost may be the primary factor driving the decision. It may needn't always be so, right? So concluding remarks before we begin to lock horns again. So there are lack of head-to-head trials in SPA between biologics and small molecules. But even if head-to-head trials come, they will not be able to answer the questions of which patient to select for what drug. To the same patients, the different patients react differently to the same drug, and when and how to switch from one class to another, and is combination possible. That means to say that our class of drug completely cannot be dismissed just because of existence of another class. So this is all the medications we have, and there can be only one Gunda in the market, and that's a biologic. So for men may come and men may go, but I gone forever. That's what your biologic says. Thank you. That's it.
So,
Stop sharing.
so Dr. Lakshmi, if you want to take a rebuttal, it's your time.
What slides again?
Downloads menu.
There only, oh.
Okay, my friend has told lots and lots and lots of data, 52 trials and 57 trials, and I have only 5 trials left in my hand. Oh my God, we are newbies. We have only 5 trials left in our hand, and we are recently FDA approved, not like 20 years, say they have been running in the market. Yeah, obviously they'll have more trials, right? But we have been achieving what data wise we have been she has showed that we are in the 3rd place next to your TNF alpha, IL-17, and then our JAK inhibitors. But coming to the data, so as she said, in the network analysis there is a line thicker and wantedly, but if you see there were 2 different lines for JAK1, JAK3, and then JAK2 separately. And I would definitely say efficacious wise TNF alpha is little better. I have no data saying TNF is head-on-head trial to say that it is more better than the thing. But what had is achieved, tofacitinib and JAK inhibitors has achieved when you compare it to the TNF alpha inhibitors. Patients have told us that it is having equal amount of effect than the yes. And as we had showed in the analysis, I would like to put the data again about the efficacious, about the meta-analysis. The efficacy, if you say it was 60%, this is showing 52% and 50%. Not much of a difference between the 52% and the 60%. I think head-on-head trials might prove us that whether it was significant, whether there was a significant difference between the 2 things. Coming to in future, definitely there'll be more trials on tofacitinib and everything. And also I would like to mention about the radiographic progression, which we mentioned that only TNF alpha had shown radiographic progression. But in select access 2, if you can go and check in the primary paper, it has shown that in 2 years, there has been minimal change in the radiographic progression, even with upadacitinib, which has showed that smaller molecules are equally effective in preventing the radiographic progression compared to your TNF alpha. Next point was again about the side effects. So coming to this paper on the side effects, compared between the, this was a head-on-head analysis between the JAK inhibitors and the TNF inhibitors, and how many percentage look at the cardiovascular risk, which was mentioned that this tofacitinib was showing more cardiovascular risk. If you see the TNF alpha and stroke was 3.94. Yes. So if you can see the stroke data and this was actually a crude data when they had seen the other comorbidities of the patient and corrected it. If you see the percentage was almost similar, 3.8, 3.7, 5.2, 4.9. The venous thromboembolism was 34.9 and 34.3, which was not much of a significant between the two data when head on head they compared between the cardiovascular risk. So I think that just because there is a black box in the thing, that doesn't mean that it is not equally important. Like it's also same amount of side effects is seen in both the groups. That was what I was saying. And we had been recently taught about this ACR criteria, how this Spanlar criteria is showcasing that interleukin-17 and TNF alpha is in the first place in the JAK inhibitors. I think in first year I had presented about the treatment guidelines of axial SpA. At that time, only tofacitinib was just FDA approved. And it was not even in the recommendation. Now that it has come into the recommendation, down the line in 5 years, it could be still, with more data coming up, it could still be in the top, where JAK inhibitors versus TNF versus interleukin-17 could be all in par. It is just that data is evolving. Next, I think malignancy was also sought, but this data showed that there was equal side effects between the two groups. But I would still say tuberculosis is maximum with the TNF alphas compared to your tofacitinib group, which whatever data we can take, which is thing. And then coming about, there was this thing called cost incremental efficacious thing. Whatever it is, I feel that maybe I had not put in the data about today about tofacitinib data on how the patient is feeling post that, like how TNF alpha. But I feel as a clinicians, we have treated so many patients and so many prescriptions. And after so many prescriptions, I've seen that both the groups have equally responded really well. Only thing, lack of data doesn't mean that the drug is not acting. Lack of data is because we are just new in the market. But then down the line in 2 to 3 years, there is going to be data and there is going to be a change, which is definitely going to happen. I think whatever counter she has given, I have told about it, side effects, cost, and strength of the molecule, everything. So, yeah, we did put some.
Okay, Dr. Srilakshmi has given her rebuttal. Dr. Deepti, do you have any more point to make? Just 1 minute you have to make any more points. But no fresh points.
No fresh points. Yeah, so regarding adverse effects, I think a lot was spoken, but the data I showed was almost of a huge RA population, which is no way comparable to what is being shown here, because the oral, so what I was trying to say is the oral surveillance trial was one which showed the increase in the cardiovascular side effects. That is the reason that has come into the recent guidelines also. And the next point I wanted to make was the loss of selectivity. As she already told, JAK inhibitors are a really wide box. If you target one, then there will be a lot of downstream side effect also. But the biologics are very selected targeted molecules where the downstream side effects are much lesser and the selectivity is higher when compared to JAK inhibitors. I think the rest of the points are covered in my presentation. So that's it. Thank you. Rest my case.
So thank you, Deepti and Srilakshmi, for presenting both viewpoints of the aspects regarding each end of the era of biologics is over or not. Now, after this debate, I'll move to the house and ask the house which side they want to go for. Okay. Yes. So we'll go back to the main question. Okay. Yes. So the house includes Varsha ma'am also.
Yeah. Very, very interesting debate. And Deepti, Srilakshmi, very well fought.
Thank you.
I think you've all given us so much to think about. Even my son was listening.
Okay, fine. So I'll go back to the house and ask the house. So
Yes.
is the era of biologics over? Okay, those who are for the motion means supporting Lakshmi that yes, era is over, can raise their hands. Okay.
Obviously.
Sham has voted in favor of Lakshmi. Okay, ma'am. Varsha
Okay,
ma'am.
okay, I have a few comments here. See,
Okay.
Srilakshmi was excellent in her debate.
Hmm.
The only problem here lies that it's a new kid on the block, right? So JAKs are a new kid on the block, and Deepti had a slight advantage in that her drugs have been around for a longer time. There is a lot of data. And if we look at long-term side effects or long-term effects, we know more about biologics than about JAKs. So I think teeny weeny advantage of Deepti over there. So I'd like to vote for TNFIs over here.
Okay, so the House has voted. So House has decided after this debate that the era
The
of
era of biologics is not yet over.
not yet over. So the situation may change. We can have this same debate
Yes.
after a few years, and results may change.
Yes, yes.
Right?
And
Because
one more point. We need more data from India because almost all the data that you girls presented was from,
Yes.
outside India.
Yes, yes.
And we need more data on tofacitinib, on JAKs, because we use JAKs preferentially, I
Yes.
think. In our practice, that is what our, standing has always been, right? Because we are veering towards JAKs in our practice.
Yes.
Although inside we know that the era of TNFs is not over.
Yes.
Or IL-17s is not over.
Yeah. So
we need data.
the use of small molecules is definitely increasing. It is challenging the fortress of biologics, but the era is not
yet over.
Okay.
Wonderful debate. Both girls have done so well.
Yes.
Wonderful slides. I wish I was there right now to enjoy it.
Okay. No problem. No problem. Okay.
Excellent.
Okay. Thank you.
Deepti Shri, great.
Thank you. Thank you. Thank you, everyone. Okay. Signing off.
Bye-bye. See you tomorrow, guys. Bye.
Bye.